Having undressed the patient, what would you do next?
Well, Andreas, I prefer to start with the hands of the patient. This is usually the first physical contact between clinician and patient, and in my experience, starting with the hands helps to initiate trust between the clinician and the patient and helps to put them at ease.
Mrs. Smith, can I have a look at your hands? Thank you.
The hands and nails can reveal a large number of pathologies. Let us look at some of these in more detail. We can break down this procedure into 6 steps: temperature, hydration, nails, palms, joints, and skin. A large variation in hand temperature is often a normal physiological finding, but in some cases it may be significant. Cold hands may indicate low cardiac output, poor peripheral circulation, Raynaud's phenomenon, side effects of certain medications, and nervousness, especially if they are also clammy. In contrast, excessively warm hands may signify high cardiac output, a common sign of thyrotoxicosis. It may also indicate liver disease, systemic inflammatory conditions, or it may be present in a pregnant woman or those receiving estrogen therapy.
Turn them around for me.
Look for evidence of cyanosis. Peripheral cyanosis is blueness in the exposed peripheral parts of the body, such as fingers, toes, nose, and earlobes. It can be a consequence of poor vascular perfusion to these tissues. The most frequent transient cause, especially when exposed to cold, is vascular reactivity, causing vasoconstriction, as in Raynaud's phenomenon. If peripheral cyanosis is more permanent, consider vascular diseases such as atherosclerosis, thromboembolic pathologies, hypertension, diabetes, dyslipidemia, and the acute onset of Buerger's disease seen in smokers. In peripheral cyanosis, the function of the lung is normal, and essentially the amount of oxygenated hemoglobin leaving the left side of the heart is also normal, in contrast to central cyanosis. Pay particular attention to the nails, as they may indicate specific conditions, especially when these are chronic. Look for any of the following features: clubbing, Leukonychia, Koilonychia, Splinter haemorrhages, pitting, Onycholysis, Beau's lines, and Paronychia. These features will now be discussed in greater detail. And again, if you are familiar with these, skip to the next chapter. Clubbing is the physiological thickening and broadening of the soft tissues surrounding the terminophalanx under the nails. The nails may become curved both longitudinally and laterally. Clubbing shows the following progression: fluctuation and softening of the nail bed, loss of the normal angle between the nail bed and the nail fold, increased convexity of the nail, thickening of the whole distal phalanx, and striation of the nail and surrounding skin. It is best assessed in the early stages when the nail bed becomes softer and can be rocked from side to side. As the underlying condition progresses, the curvature becomes more prominent. Clubbing can also be assessed by placing 2 nails back to back against the light and try to observe a diamond shape formed by the 2 nail bed angles. In clubbing, this is obliterated. Curvature alone of the nail may not be significant enough to diagnose clubbing and should be supported by evidence of soft, unstable nail bed. Therefore, apparent clubbing may have no significance in a healthy individual, such as those with familial or racial variations. However, when clubbing is observed, you should consider primarily long-term pathologies, principally of the lungs, abdomen, and heart. In more detail, finger clubbing may be caused by diseases of the lungs, like lung cancer, especially bronchogenic carcinoma, interstitial lung disease, bronchiectasis, abscess or empyema, pneumoconiosis, pulmonary sepsis, chronic infections, especially tuberculosis, and fibrosing alveolitis. Diseases of the heart, subacute bacterial endocarditis, cyanotic congenital heart disease, and chronic hypoxia. Gastrointestinal conditions, cirrhosis of the liver, inflammatory bowel disease such as Crohn's and ulcerative colitis, esophageal cancer, polyposis, and other conditions including hyperthyroidism and thymoma. Please note that in many instances, pathologists do not necessarily produce clubbing, especially when treated early. Leukonychia totalis refer to a state where the nail becomes white and opaque. Do not confuse this with the odd white spot, which is not clinically significant. Leukonychia is seen in chronic conditions associated with hypoalbuminemia. Examples include liver disease associated with cirrhosis, proteinuria associated with nephrotic syndrome, in severe malabsorption and malnutrition, and protein-losing enteropathies. In Koilonychia, the nail appears flat or even with an upward curvature, also referred to as spooning of the nail. The nail may also have raised longitudinal ridges and is thin. Koilonychia can be seen in iron deficiency anemia. Splinter haemorrhages are small linear red-brown streaks seen under the nails. Splinter haemorrhages can be found in manual workers, especially if they are located in the distal portion of the nail. In this case, they are not significant. However, splinter haemorrhages may signify infective endocarditis, vasculitis, scleroderma, and systemic lupus erythematosus, or SLE. Please note that in practice, the majority of patients with infective endocarditis do not present with splinter haemorrhages. In pitting, the surface of the nail is dotted with small depressions. It may be indicative of psoriasis, severe dermatitis, reactive arthritis, and alopecia areata. Onycholysis is caused by a premature lifting of the distal part of the nail. It may become weak with a breakdown of the healthy nail matrix. Onycholysis may indicate fungal infection, lichen planus, and thyroid dysfunction. Onycholysis and pitting may be seen together in psoriasis. Beau's lines are deep transverse grooves on the surface of the nails. The groove demarcates a difference in the appearance of the nail. Beau's lines may appear several weeks or months following a protracted systemic illness, high fever, infections, following chemotherapy, coronary occlusion, hypocalcemia, skin disease, in diabetics, and with psoriasis. They may also develop as a consequence of medications, severe malnutrition, and from trauma. Paronychia describes an acute or chronic inflammation of the skin adjacent to the nail or nail bed. The skin folds appear red, swollen, and are often very tender to pressure. Paronychia is a common condition which usually results from local inflammation and may not indicate systemic causes. Causes of paronychia include trauma, local infection, allergies, pemphigus, herpetic whitlow, certain medications, and, if widespread, consider diabetes, herpes simplex, or fungal infections. Also, examine the palms, their color, and temperature. Note the presence of any skin lesions or structural abnormalities. Palmar erythema is redness of the palms, especially at the thinner and hypothinner eminence. It is usually seen in portal hypertension and chronic liver disease. It can also occur in rheumatoid arthritis, thyrotoxicosis, during pregnancy, and with raised estrogen levels. For example, administration of estrogen-based contraceptives. Also, it is a manifestation of polycythemia or may be due to a skin condition. Whilst examining the palms and fingers, look out for Osler's nodes. These small, palpable, tender nodules are thought to be formed from septic emboli and circulating immune complexes. They may also be observed on the toes and soles of the feet. They may indicate infective endocarditis, vasculitis, and SLE. Please note that the presentation of Osler's nodes may last from several hours to just a few days. in contrast to the long duration of other hand features we discussed earlier. For many physicians, the presence of Osler's nodes is a rare finding. Similarly, Janeway lesions are non-tender macular lesions found on the palms and soles of the feet. They may signify endocarditis of the type caused by Staphylococcus aureus. They are also believed to be septic emboli. If you suspect endocarditis, also examine the fundi of the eyes for Roth spots.
When examining the fundus of the eyes, be on the lookout for other abnormal features such as copper wiring, arteriovenous nipping, exudates, cotton wool spots, papilledema, macular stars.
Dupuytren's contracture is most commonly seen in a patient suffering with chronic liver cirrhosis associated with alcoholism and in diabetics. Also consider this may be an inherited manifestation of no pathological significance. In cases of Dupuytren's contracture, the digits affected cannot be forcibly extended, unlike with the trigger finger. Note the presence of yellow tobacco stains around the nails and fingertips. A more generalized yellowing of the skin can be caused by Carotinaemia. Carotinaemia does not affect the sclerae of the eyes, unlike jaundice. Finally, when assessing the patient's hands and wrists, take note of any signs of structural abnormality. Heberden nodes are easily identifiable. They are bony growths at the distal interphalangeal joints. Heberden nodes are long-term manifestations of general osteoarthritic changes. They present with near symmetrical distribution when the condition is established. Bouchard nodes are similar manifestations but affecting the proximal interphalangeal joints. Symmetrical soft swellings and inflammation of the hands and wrists can signify rheumatoid arthritis. This is particularly seen in the metacarpophalangeal and proximal interphalangeal joints. In rheumatoid arthritis, there may also be ulnar deviation, boutonniere and swan neck deformities. If rheumatoid arthritis is severe, the hands may be warm, tender and swollen.